Welcome, future nurses. Today, we are diving deep into one of the most high-stakes situations you will ever face in an ER, abdominal trauma. And look, this isn't about just cramming for an exam. This is about building that solid clinical judgment that's going to save lives. We're going to walk through it, step by step, just like you would with a real patient. All right, so here's our game plan. We're going to follow the exact flow you'd use in a real trauma bay. First, we'll get a handle on the stakes. Then, we'll master the assessment, move to the critical actions you need to take, and then dig into specific organ injuries and their nasty complications. Let's do this.
So, first things first, let's talk about why this is so incredibly important. Abdominal trauma isn't just a topic in your textbook. It's a real life-or-death situation where every single thing you do or don't do can change the outcome. Third, let that number sink in. It's the third leading cause of traumatic death. But here's the part that should really get your attention. A huge number of these deaths are preventable. And you, the nurse at that bedside, you are the front line. You're the key to preventing them. You've got to picture your patient as fighting a war on two separate fronts at the same time. On one side, you've got massive, catastrophic hemorrhage. They could bleed out in minutes. And on the other side, you've got this ticking time bomb of a perforated organ spilling toxic contents, which leads straight to deadly sepsis. Your job is to help win both of those battles. Okay, so you understand the risks. Now it's time to put on your detective hat. Your number one job is to find the clues that are going to tell you what's going on inside that abdomen. And your most powerful tools? They're your own two eyes and your hands. Let's talk about how to use them. This right here is your mantra. You need to drill this into your head. Inspect, auscultate, then palpate, in that order. Look for bruises, wounds, or a belly that's getting bigger. Listen for bowel sounds. Are they there? Are they gone? Then you gently palpate. You're feeling for tenderness, for guarding, or for that rigid board-like abdomen that just screams peritonitis. And don't forget to ask about weird pain, like left shoulder pain, a classic sign of a spleen injury. These two signs, you have got to burn these into your memory. Cullen's sign is that bruising around the belly button, and Gray-Turner's sign is bruising on the flanks or the love handles. Now, they can be late signs, for sure, but when you see them, your brain needs to immediately scream massive internal bleeding, and you've got to prepare for the absolute worst. All right, knowledge check. You see this bruising on your patient's flanks. What is your number one, top of the list concern? If you're thinking hemorrhagic shock, you are 100% right. So, what are you going to do? You're getting those two large bore IVs in, you're slapping them on a cardiac monitor, and you are getting a full set of vitals like yesterday. Okay. You've assessed, you have an idea of what's wrong, now it is time to act. These are the critical, life-saving moves that you and the trauma team are going to start doing immediately. This is where you have to be a master of organized chaos. You'll be dropping an NG tube to decompress the stomach, putting in a Foley to track urine output, giving meds, but your absolute top priority is getting IV access. And not just one, you need two large bore IVs. And here's a pro tip from me to you. Have a pressure bag and a rapid infuser ready to go at the bedside, because you are likely going to be giving fluids and blood, and you're going to be giving them fast. And this is why we are so obsessed with saying large bore IV. A standard little 22 gauge is like a garden hose. A 16 gauge, large bore IV, that's a fire hose. When your patient is bleeding out, you don't have time to mess around. You need that fire hose wide open to pour in fluids and blood to have any hope of saving them. So, we've got the patient stabilized, at least for the moment. But what's actually going on inside their body? Let's peel back the layers and look at the most commonly injured organs and how that changes what we do. Let's start with the liver. It's a huge target in abdominal trauma. I mean, just look at this image. It's a massive, bloody organ. Any kind of tear or laceration to the liver can lead to a life-threatening hemorrhage. This is exactly why a patient with a suspected liver injury needs constant hawk-like monitoring for any sign of shock. So what do we do about a liver injury? Well, it all comes down to one simple, critical question. Is the patient stable or unstable? If they're stable, we might be able to just watch and wait, monitor them closely. But if they're unstable, blood pressure dropping, heart rate climbing, that is a one-way, non-stop ticket to the operating room. The spleen is another organ that can cause a world of trouble. Think of it like a big, fragile, blood-filled balloon. It really doesn't take much to pop it. A simple seatbelt injury from a car crash can be enough to rupture the spleen and cause massive internal bleeding. I've seen this one many times, and let me tell you, it's always scary.
Are you seeing a pattern here? Just like the liver, the decision to rush to the OR for a spleen injury is all about stability. And guess who is the person most likely to notice that subtle change, that tiny drop in blood pressure that signals big trouble? You are. Your sharp assessment and quick communication can literally be the difference between life and death.
Of course, we can't forget about the other players in the abdomen. A bowel injury is a direct route to peritonitis and sepsis, so you're going to be on high alert for fever, that rigid abdomen we talked about, and any signs of infection. And hey, if your patient has fractures to their lower ribs or their lumbar spine, you better have a high suspicion for a kidney injury. That means you're watching their urine output like a hawk and checking for any blood.
Okay, pop quiz number 2. Your patient has a suspected spleen injury and their vitals are trending in the absolute wrong direction. Heart rate is climbing, pressure is dropping. What is the priority? If you said, get ready for surgery, you are spot on. But what else? You're making sure blood products are in the room, ready to hang, and you are clearly communicating your concern to the whole team. You're not just a task doer, you're a critical thinker. Now, let's switch gears and talk about an injury that's often underestimated but is an absolute killer, the pelvic fracture. This is so much more than just a broken bone. This is a potential death sentence.
Just let that quote sink in. More deaths than any other skeletal injury. Why? It's simple. The pelvis is a bowl full of major blood vessels. When it breaks open, a patient can bleed their entire blood volume into that space in minutes. So from now on, when you hear pelvic fracture, your brain should immediately think massive hemorrhage. Say it with me. Pelvic fracture equals massive hemorrhage.
And this right here, this is the simple, brilliant, life-saving intervention. It's a pelvic binder. The goal in the ER isn't to perfectly fix the bone. The goal is to slam the pelvis shut, like closing a book. This reduces the space for blood to pool and creates a tamponade effect. It's basically a tourniquet for the entire pelvis. Okay, the initial crisis might be over. The patient made it out of the ER, out of surgery, but the battle is far from won. The days and weeks after a major trauma are filled with danger. And this is where your nursing skills truly shine. Your vigilant, meticulous care is what prevents these patients from dying from complications. Yeah, this is a scary list, I know. Infection, ARDS, blood clots, pressure sores, multiple organ dysfunction syndrome, these are all potential killers lurking in the background. But here's the thing. You have the power to stop them. Your fanaticism about hand hygiene, your careful respiratory assessments, your diligent skincare, and you pushing for early mobility, that's what makes all the difference. So let's end with this thought. What's the most dangerous abdominal injury of all? It's the one that gets missed. And your most powerful tool to prevent that from happening isn't some fancy scanner or piece of tech. It's your brain. It's your clinical judgment, your ability to put the pieces together, and your voice to advocate for your patient. That is what saves lives. So the real question is, are you ready to be that kind of nurse?